All right. So, hello everyone. Please allow me to introduce Dr. David Bernstein and Henri Ullmann. Dr. Bernstein is one of the Harvard Combined Residency Orthopedics residency programs, H-Core. He's a fourth year resident right now. He's also doing his PhD in value-based care. He has a background in economics. You did your BA in economics, I believe, and you did your master's in entrepreneurship and innovation.
I did, yeah.
Right?
Yeah, absolutely.
Yeah, and Henry is one of the research interns here at FARIL. Most of his work here is focused around proms. He's coming in from Switzerland, and we're happy to have you both to talk about value-based care today and what that entails for healthcare in general and orthopedics in specific. I'll let you guys introduce yourselves a bit and how do you relate to this topic specifically, and what's your background on it? So why don't we start with you, David?
Absolutely. Well, thank you for having us. This is awesome to be here. And as you mentioned, value-based healthcare is such an important topic, and it's a topic that gets a lot of attention. And so I really got into this initially because the health system is broken, whether it's in the United States or any other country, frankly, around the world. We spend tons of money on healthcare, yet we don't even know the outcomes that we achieve for that matter to patients. We continue to pay in almost every country in the world for the amount you do, not the quality or the outcomes that you provide. And so, for me, this is an exciting opportunity to be in healthcare because for a problem that's been so big for so long, for so many, we still don't have an answer and we still don't have a solution. So if you can start to move the needle towards a value-based healthcare system, I truly think that is the solution. And little progress has a big impact on a lot of people. And so I really got interested in this because I think there's a better way to deliver care, engage patients in their care delivery journey. And I've had a great privilege of working with a lot of the leaders in the field of trying to move this work forward, and can certainly touch on that. And it's exciting to have Henri here as well, who's helping to lead this work too.
Yeah, so the way I got started in this whole thing is that I've been through my medical school path. I've been having some internships in the hospital, and you kind of always see the provider side of things, and you see how providers get burdened with more and more patients and, more time constraints on their outpatient clinics. And I was just always curious to see if there's a better way to manage the patients and the care and to divide this up to see how we can, not only optimize the patient care side of things, but also the healthcare provider side of things, to free them up as well, to have them also, to facilitate them to deliver better care for the patients that need it the most, while also improving their quality of life, therefore enabling, better care for the patients as well in retrospect. So
right.
That's kind of my background in it and how I got started in this whole thing.
Right. Yeah, I'm excited to hear about your thoughts through this podcast, but I want to start with this, is when I hear the term value-based care, right? When I hear specifically the word value, for me, as someone who's not involved in what you guys do and with the valuable work that you guys do, when I hear the word value, for me, the word value means, for example, for me, loyalty, honesty is value, right? My value system is based on honesty, loyalty, and so on and so forth. For your work, what does the word value stand for?
Yeah, I think it's a really important question, because I think the definition is at the core of some of the challenges we face today, and having a set language and clear definition allows us to really move towards value-based care. So value-based care, broadly speaking, is a system that's really designed around patients. Historically, we've really focused on designing care in hospitals in silos based on what physicians and nurses and fantastic people who need to be there to deliver the care. It's the only industry that we're really focused around the people delivering the service versus receiving the service.
Mm-hmm.
Every other setting, we're focused around the person receiving the services. So that's kind of the backdrop for this. Value-based care, the classic formula, and I've had an incredible honor working with Michael Porter and Elizabeth Teisberg, who helped develop this idea and this concept around value-based healthcare. The classic equation that everyone thinks of is value is outcomes over cost of delivering that care. But it's a little more nuanced than that for a couple of reasons, I think. So one is, typically in healthcare, and this is not unusual, we like cutoffs. We like numeric values of, well, and I get asked this all the time. They're like, well, how do you know that this is a high value intervention that I want to implement? That what's the cutoff? Is it 0.6? Is it 7? Is it 400? Like what using that formula? What is the cutoff? And the challenge is it's really a strategy. It's a mindset of moving towards optimizing those outcomes for patients for the dollars we spend. And it isn't a numeric value. There is no cutoff. And that really gets under people's skins in healthcare because they like having some sort of cutoff value. And the reason I think that's important to understand is that numerator is very hard. So the outcomes part, it's really multifaceted. And that's another thing, is someone's like, well, how do I calculate the numerator?
Right.
Part of the numerator, and I know Henri feels this is important as well, are patient-reported outcome measures.
Right.
But it's not that we ignore mortality. It's not that we ignore patient experience. It's not that we ignore access. It's all of those elements come up with this idea of a holistic measure that we understand as outcomes that matter to patients, and then the cost of delivering those is in the bottom. But there is no single value that can measure all those elements. And the best thing, and then I'd love to hear Henri's thoughts on this, the best analogy I've ever heard is from Professor Bob Kaplan, who I work with at Harvard Business School, absolutely brilliant gentleman who came up with the balanced scorecard and time-driven activity-based costing and all these amazing things. But he always talks about, he goes, if you get on an airplane, you got on the airplane, you looked in the cockpit, and you saw one average of like height and air pressure and speed and all of these things, and it just said 7. Would you really feel comfortable on that airplane? Because if it drops and an alarm starts going off, you have no idea what in that average is causing it to go off.
Right.
The fact that in healthcare we want to simplify a patient and patient outcomes to a single number is, to me, just not a realistic expectation for the same reason. It's just we need to be able to target different interventions for the different aspects of that numerator, and if we try to boil it down to a single number, it's just not delivering the best care we possibly
But I assume that it's boiled down to a single number for a reason, right? Because if it's so multifaceted and it's so difficult and complicated to account for all these factors that weigh in to outcomes and the values that you're trying to achieve in healthcare. So how do we make it simpler? Because doctors are busy, and general healthcare providers are very busy, and it might be really hard to incorporate these things into their daily workflow or their administrative tasks on top of everything, right? So I'm assuming you have a lot of thoughts on this, and I want to pick your brain on it, especially like Henri, your experience as well. So why don't we hear from you, Henri, first?
Well, I think kind of to make things simpler, I think what I've been seeing, what's kind of going wrong is that you have big corporations bigger hospital groups try to just incorporate value-based healthcare for their entire organization versus not picking out a specific patient group to focus on first. I think you have to find a group of patients that have a similar care request for which you can then focus certain interventions on, from which you can start off, and then you can see what works, what doesn't work, you can measure, and then you can use the scores in the end to see if you can build partnerships and expand that patient group and these care requests to see if they also fit other groups. But I think it's starting off with a group of patients with kind of a unified set of problems, basically, and trying to target those individually and see how far you get with that, and then you can see how you can expand that to a larger scope. But I think starting off with a smaller group is kind of the best way to simplify, instead of looking at we want the best outcomes and we'll do whatever it takes to get there, without actually approaching it from kind of a more narrow perspective.
Maybe they're being too ambitious with their approach to value-based care, and it's not really panning out with anything at the end.
Yeah, and I think, kind of building off of what Henri said, because I think it's really important, one of the things is people think value-based care is a payment model, or they think value-based care is measuring outcomes, or they think value-based care is this, that, or the other. Again, it's really a strategy, and part of the simplifying aspect is a few things. One is measuring what matters to patients.
Right.
The challenge with that is fewfold. It's really hard and unusual in a system that has never done this before.
Right.
So it's much simpler to just measure process metrics, because it's documented in Epic or in whatever electronic health record. I mention Epic because we use that a lot, and it's easy because you click a button and like that can be measured on the back end very easily. It takes no other input. I put in a code for this procedure, this diagnosis, and I can measure it. Patient comes back, I can easily measure patient comes back. The real question is why, how, what is the problem, what aren't they achieving that they want to? And I think orthopedics is a perfect example, and why it's been kind of this playground for value-based healthcare initiatives is people get orthopedic surgery typically, on average, because they want decreased pain, better function, and improved quality of life. I would challenge anybody listening or any of you to go to an orthopedic surgeon, anybody, fantastic ones, and say, how do you do on those three categories? And I would suspect that the response you will receive is, oh, my complication level is much lower. If that, right? You may not even get that, but a lot will say, well, my complication is lower. Patients don't go in saying, I really hope I don't get a deep vein thrombosis. Like, I want my total knee, but like, don't give me an infection, right? Like, the bar is so low. And if you went to any other industry and you said, hey, here's a computer, I hope it doesn't catch on fire, you'd be like, that's my like bar of like, I want a new computer, like the outcome I'm concerned about is it catching on fire. That's ridiculous. It would be recalled. That's how crazy it is. But in the US we measure mortality for bunions. Right. Like if you go in to get a bunion and you're like, please don't kill me. Like the bar is so low. Yeah, definitely. So we need to measure this and have it to be robust. And the last thing I'll say about that I think is really important is one of the things that really, is important is that it's okay to measure and then to work to improve. And there's a lot of research that's coming out. It's a great study by Kevin Bozick and his team, and a gentleman named PJ who helps lead a lot of their value-based healthcare work at Dell Medical School at the University of Texas at Austin. What they do is they basically just collected this data and showed it. Unblinded, showed it to surgeons. Orthopedic surgeons and physicians in general are type A personalities. If you are last on that list, even if you're not penalized financially, even if you're not penalized because of OR time, the chance you want to be and you're okay with being last on that list is almost zero. Right. Inherently, over the subsequent year that they studied, everyone got better in every metric.
Right.
Just measuring is important.
Just simply showing them these numbers.
Just show them the data. Yeah. And the other thing is, it's okay. This is the other thing that drives me nuts sometimes in healthcare. It's okay to not be the best, but to strive to be the best. And if the difference between the best and the worst is 0.00005%, that's better than not knowing that the difference between the best and the worst is, X percent. Right. And you may be the best in one category and not in the other, and part of it is learning from each other to make sure everybody gets better. Right. We don't measure it. If you don't measure something, you don't know if you're improving or getting better.
And like you mentioned something that made me think, which is the bar is so low, right? Yeah. But the way I look at it, our healthcare system is so expensive. Yeah. So if we do want to raise that bar, what's going to happen to that, price tag? Yeah. So how do we mitigate an increase in price tag? Because I'm assuming if you want to raise that value of your healthcare, or raise that bar at least, that price tag is going to go up, right? Because you're going to be pouring in more resources, and whether it's educating healthcare providers, whether it's bringing in, more expanding your facilities, bringing in more equipment, whatever that the case be. So what's going to happen on that end?
Yeah. Well, I think, and let me know what you think as well. I think the ideal is that you don't have an increase in costs. That's the idea. You have a redistribution to the areas where you need it the most. You can measure outcomes. You can see where are we having success, where are we not having so much success, what is working, what is not working, and then reallocate and help departments that are overwhelmed by patient numbers, and kind of help them out more and kind of see how we can approach from that perspective.
And I also think that we don't even measure to know. There are likely there's so much waste and there's so much inefficiencies for things that don't add value for patients, that if we could streamline that, I actually think and would suspect it would be lower cost. And one of the problems that we're having is, we just published a paper looking at this. It was more of an opinion piece, but the classic way to cut cost in healthcare is to just say, everybody cut 1%. That is the most inefficient, non-business savvy way to do that. Because what you should really be doing is you should not cut. You should actually be investing more in things that increase value and increase your revenue, and kind of siphon off resources from things that aren't working as well. It doesn't mean that it's easy to do that. I mean, there's people involved, etc. This is not an easy task, but it's such a shortcut to just say everyone cut 1% of your cost,
Right.
instead of targeting and understanding. And part of that is saying, okay, if I do that, I need to measure the outcomes part of that kind of relationship of outcomes and cost, and see how it moves. If it increases, I need to put my resources there, and then I can move resources over. And it doesn't mean that it doesn't change. That's the other thing that I think is really important. People are like, well, if I put more resources in this in orthopedics, orthopedics already gets paid X amount, or whatever subspecialty. Like, why would I do that? Well, you need to measure to know that. And right now we're just kind of like putting our finger in the air and being like, well, it seems like we should just cut 1%.
Right.
And so I don't necessarily think it's going to increase costs. I think part of the problem is we know nothing.
Right.
So we are truly like shooting in the dark here and being like, well, I hope this works.
Yeah.
And the other thing is we don't even know the cost of delivery. We use proxies all the time. Price, negotiated reimbursement rate, all of these things. That is not the cost of delivering the care. That is a extraordinarily poor estimate.
Right.
The only thing we know is if we make money, just so happens that for whatever our costs are, we made more, so we must be making more than our cost.
Right.
But in healthcare today, we cross-subsidize constantly. Orthopedics.
Well, what does cross-subsidize?
Yeah, so that's a great question. So if orthopedics, let's say it costs $100, they get reimbursed $200. But and we cross-subsidize in many ways, so across insurance companies and across subspecialties. So in orthopedics, for example, today, we may make above whatever the cost is.
Right.
But in a mental health service where we clearly need more resources, we may make below. And so some of the orthopedic money then kind of gets siphoned off to make sure that mental health services become whole. Insurance is even worse and is even more common. And this is when they talk about like patient mix of insurance. Medicaid tends to pay at or below cost. Medicare is roughly the same, but private insurance tends to be slightly above. So if you're a safety net hospital, which are critically important to the well-being of our citizens and everybody, and you don't have the high private insurance group to cross-subsidize the people who take the same procedures and illnesses and to help kind of offset that, we're in trouble. And so designing a system, value-based healthcare is trying to design a system that you reward based on the value you provide,
Right.
the outcomes that are achieved, and not on kind of traditional fee-for-service, oh, this is cool, we use this technology, we'll pay you more for it.
Okay.
So-
Okay.
Can I ask you a question
Yeah,
on that then?
please.
Because what's your take then? Because in some ways you have departments that are struggling because they have too many patients, so on, or they don't have enough doctors, or they don't have enough resources. Where they could maybe perhaps do contribute quite substantially towards patient health overall. So like mental health, for instance, they could help out with a lot of pain issues that patients are having when
Absolutely.
orthopedic surgery might not be such a good option for them. So in that sense, I guess cross-subsidization is helpful to kind of ripen them to a point where they can actually contribute to this whole system as well, right?
Yeah, I think you touched on a really important point, and that's why I think within value-based healthcare, there's kind of like 6 elements of the quote-unquote playbook, and
Right.
I think the element you're touching on, and very smartly so, is the element of like an integrated practice unit.
Right.
At the moment, mental health and then psychiatry and all the support services are in one group.
Right.
Orthopedics is in another.
Right.
We may see a note come across and we're like, oh, that's interesting, right? But if you really wanted to optimize a patient's outcome, and this is some of the great work being done by some of the leaders around the world in value-based healthcare, they have mental health services within orthopedics.
Right.
So David Ring, Dr. Ring is probably the person who really drove this forward in orthopedics and was like, sure, there's a biomechanical and anatomic reason for your pain, but there's a huge mental component, and if we as orthopedics ignore that,
Right.
we're never going to reach the outcomes we could. And so trying to integrate around patient conditions, as you mentioned earlier, Henri, I think is critically important.
Yeah, I think as in general, healthcare providers tend to tunnel vision into what they personally do, and
it's the structure we've had for forever.
Yeah, and I don't blame them
easy.
individually. I do blame the culture and the system that we were fostered in over time. I do want to take a step back and focus more on key individuals in value-based care.
Sure.
What do you think is the value of the PCP in value-based care?
Sure.
So how important is their role in that? Because you did mention you need something that ties all the departments together, and also Henri mentioned that as well. There is a need to tie all these departments and key players together.
Mm-hmm.
So the first thing that popped in my head is a PCP, right? Mm-hmm. So could you expand more on that?
Yeah, so one of the things when we teach at HBS, the case study, is a lot of times people will leave and say, well, this must work in orthopedic surgery, but how does it work in primary care? One of the challenges in primary care is this goes back to the other fact that there is not a single payment model. It's not that bundled payment is value-based payment. So there's different forms of kind of ACOs and population-based payments to take care of certain individuals. One of the things in a value-based world is better trying to segment the population. And so as Henri incredibly insightfully said earlier, we historically have said, okay, amazing PCP, I want you to see a headache followed by an ankle fracture, followed by heart failure, followed by a bellyache. And I want you all to see that in an hour, and I want you to be an expert in everything. And I don't want you to refer to somebody in case you really need to, because it's a waste of resources. And I'm not going to pay you enough to do this, but I want you also to respond to all the inbox messages you have. And if you don't, you're going to get penalized because there's a quality metric of speed to response.
And you have to chart for
everything. And you have to chart for everything. And if you don't finish your notes by the end of the day, you also get penalized. I mean, we put so much on the core element of healthcare, which are the incredible PCPs who try to keep basically the glue of our health system together, that one of the things in value-based healthcare that we talk about is, can we better segment the population? So a perfect example is Oak Street Health. Oak Street Health now was bought by CVS, but we have a Harvard Business School case on Oak Street Health, and there's a new one coming out by Dr. Tom Lee, who is a primary care physician at the Brigham, and then is the chief medical officer at Press Ganey, and Professor Lemore Daphne, who's brilliant at HBS as well. The two of them are collaborating on an update to this case. Oak Street Health kind of turned the whole idea of primary care on their head, and they segmented the population for a certain age group, Medicare patients, and they sought specific groups of people who they then could say, okay, these groups of people need these additional resources. And so what they did, for example, is they have a community room. They pay, because of the way their structure is with Medicare Advantage, they pay for transportation. If you need assistance with X, Y, or Z, they can pay for it. And in a historical model in primary care that's fee-for-service, those aren't reimbursable. Mm. And when you start designing and segmenting the population in a way of great, we'll take care of Medicare Advantage. A lot of times they entered communities that were underserved. So we're going to also decrease health disparities. And we're going to segment the population. So to answer your question, I think one of the problems a lot of times with value-based healthcare and primary care is we need to figure out how to segment, to understand patient segments and care for patient segments that are better aligned and similar. And it doesn't have to be, because one of the things that primary care physicians understandably say is, well, I went into primary care because I want to take care of everything, or I want to take care of a broad scope. But the problem with it is we're not saying you should only take care of heart issues, but can we segment the population so that the needs are similar enough that we don't have to then continue to think about a wider array of needs for every single thing that could come in, and can we segment it in that way? So
it's not only looking at the numerator, as we mentioned earlier, but also segment the denominator so that it fits the numerator accordingly.
Yeah, and really just segment the population so that you're not wasting resources, right? Because if you have a primary care office and you have someone because every 50th patient needs physical therapy, and you have this person sitting there waiting for that patient to come in. Can you design a system where the primary care aspect is segmented in a way where 95% of the patients, these are the 4 people they'll need.
Right.
So we always have those available, and if we need the others, it's not that. The other thing about value-based healthcare is they're like, people love saying, well, what about the one time that blah, this happens in the current system.
Right.
So
not even in healthcare.
Not even in healthcare, right? Like designing a system, every system has ways that it can be gamed, has ways that it can be impacted that weren't foreseen. The problem is not that. The problem is knowing what those issues are and having solutions to them should they occur. And so I think that's really important.
Yeah. I was actually curious also because you have your background is from Europe, right?
Yeah,
and I want to hear your perspective from your experience in Europe and healthcare in Europe, because we hear a lot about the healthcare in Europe and how amazing it is. How do you think the Europeans approach value-based healthcare?
That's a tough question. I think you have to realize first off that Europe is a pretty big continent. So, I mean, it's comparable to the United States, but they are all separate countries, so every country does it differently, right? And my experience has been fairly limited to kind of Switzerland, Germany, and the Netherlands. I think similar to here, you have the primary care providers that take on a huge burden of the entire healthcare system and try to kind of manage everything at the same time, but referrals are slow. It's hard to get spots in radiology practice. You always get transferred to a physical therapist, but there's no actual communication between the GP and the physical therapist on that end. There's you go there as a patient, tell them what your problem is, you get sent back, then your insurance runs out. So I think there's a lot to be said for integrated practices in that sense. And I think like my little sister, for instance, she has diabetes, and I see her, she has to go to the ophthalmologist, she has to go to the hospital to the endocrinologist, then she has to see her, primary care provider, then at some point, she's, getting older as well, so she has to go to the gynecologist, and because hormones have an effect on diabetes and insulin levels as well at some point, right? And I think, while the gynecologist can be kind of taken out of this equation, but if you provide, something where you have primary care providers kind of more together, linked better with an endocrinologist and ophthalmologist, kind of to serve a group of diabetic patients, for instance, maybe some physical therapy as well to make sure their footwear, we're in foot and ankle orthopedics here, but that the footwear is correct as well. Maybe a neurologist, then you can really, reduce costs in that sense, provide more value to the patients, and hopefully have better outcomes for both the provider
so
and
the Europeans
the
still have a lot to go when it comes to value-based healthcare as well, right?
I think we all do.
Yeah.
I think we all do too, and I think one of the most impactful slides that Michael Porter always shows is wages and spending on real wage growth and GDP growth is actually less than healthcare growth.
Right. Yeah.
That's like an incredibly impactful slide, and because exactly what you said, people are like, well, when there's a single payer or this, like that's not a problem, but it's still a problem. It's just it's a delivery issue and a system design issue, regardless of who's paying. Like it's just a overall thing, and it's interesting you mentioned diabetes is a perfect example. So in the Netherlands, there's a company called Diabeter.
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 How do you? Sorry.
Diabeter.
Okay.
It is for patients who have type 1 diabetes, and they are an integrated practice unit, and there's about 5 of their clinics. Their outcomes in diabetes care is incredibly, it's just mind-blowingly better than like everywhere else. And part of that is because that's a good example of its primary care, a chronic condition. They've segmented the population. They don't take care of type 2 diabetics, I don't believe. They take care of type 1 diabetics, and they are completely integrated, and they have relationships with hospitals and others if they can't manage it there. And their outcomes are incredible.
Right.
Their work has been highlighted by the World Economic Forum, et cetera, and the chair of the board, I believe, is Martin Ackerman, who just can speak so eloquently to this idea that if you segment the population right, and you design, this all came about because what was happening in the Netherlands, and it was not unique to the Netherlands, and so that's important to state, but people were tracking their hemoglobin A1C and their glucose, and like they'd write it occasionally in their notebook, and then they talk to the endocrinologist, but then they talk to their pediatrician, and then they'd go see someone else, and they'd be like, oh, I forgot my notebook, but neither of the two shall talk, and then the person got admitted because they had a complication because they had diabetic ketoacidosis or whatnot, like a terrible outcome. They were like, and people physicians got frustrated, and they were like, how is this an acceptable way to deliver care? And so they redesigned it, and it's not that was easy. It was challenges. Took out extra mortgages to pay for their own first clinic. They had to negotiate with hospitals because of the structure, and every country is different in that way. But the fact that we don't do that, and that it's so much easier to come up with excuses of why we don't collect PROMs, why we don't measure costs, why we don't deliver care in this way, than it is to say, like, I'm going to figure this out. It's not a healthcare thing. It's
and I think measuring and collecting these important metrics, at least the way I see it, maybe it's not very attractive to the current practices, because it does have, or probably some people do see the gain on the long term, but because we're so focused on the short term gains and the short term advantages that we can gain in our practice, we don't really necessarily invest ourselves in collecting them or measuring them, I feel like. But yeah, I mean, on the long term, maybe some people do see it, maybe others don't, but I kind of understand why now people don't really care about measuring, or not really care, but put the effort and the resources and the energy into measuring PROMs or outcomes or costs and things like that. In their own individual practices.
Well, I think the issue partly is also that they have not been well integrated, and they have not been incentivized properly, right? You have, I think, what I can see if you do research with chart reviews, you see that PROMs have been filled in a lot more reliably after COVID because of things have been more digitalized. I know there's been some studies done where they've shown that it doesn't really matter if you give them a paper form, an electronic form. Either way, patients will be just as happy filling in these PROMs at the end if the provider pushes them to. But just having patients having them check in beforehand, calling up before the appointment, having the ability to have like one more point of access to them to send them PROMs to fill in beforehand helps. But I think the other problem is that it's not well integrated how to use them in practice. I don't know what your experience has been with that.
Yeah, I think it's starting to get better, but I think the other challenge is how do we use it? And I think one of the problems is, as you mentioned, we're seeing, 30, 40, 50 patients in a day. You're trying to do a lot of things at once. And, one of the challenges is people are like, well, this is a questionnaire, it can be biased. Sure, it can be, but there are brilliant psychometricians who are experts in developing these robust questionnaires that are scientifically validated. I mean, I can think of one in the Netherlands, Caroline Turwey, who, she's brilliant. Her entire life is dedicated to making sure these instruments are as robust as possible. And they are. And sure, you can fill it out in any way to game the system. But the way the scoring is, you don't really know how that necessarily works. And so, but again, it's like with everything. It doesn't mean we don't measure it. I mean, it's the same with anything that we collect. You can game the system in some way and figure it out. So, a lot of times people are like, I don't know how to use this, and it's probably not accurate. That second part drives me nuts. It's 100% accurate. And it's the same with, a silly example, it's the same with like Yelp reviews, etc. They're different. They're completely different. The only reason I compare them is people are like, well, if the patient's, doing well, and they tell me they're doing well, that's all I care about. But well is on a spectrum. And with Yelp reviews, it may be the best restaurant in the world. You're still going to find the one person who games the system and puts 1 star and says this was the worst experience of my life.
Right.
That doesn't mean you don't collect data. I mean, the argument that there's a bad data point, we would never do science, right? Like, that argument to me is such a flawed argument.
Yeah.
And the other thing that's really important about PROMs is it's a tool in the toolbox. Right. You should not be punished or rewarded just based on PROMs. You should not just collect PROMs. You should not ignore the exam. That's the other thing. It's another tool, but it's a tool that I would argue should be substituted for the ridiculous measures of like urinary tract infection post-operatively for ankle fusions. Like, sure, is it possible? Sure. And does it happen? Absolutely. But I would rather know function, pain, and quality of life and be judged on that's related to the surgery I did than something that is tangentially related because it's in healthcare. And one of the things that I think is really important is that because it's a tool and not the end all be all, when we think about it, that's how we use it. So a perfect example is, if you're sitting there, there's a lot of research on like what the cutoff for PROMs may be to gain some benefit for the patients. It shouldn't be used as healthcare hates this, but it shouldn't be used as like a yes, no, do it or don't do it. The way it should be used is, this person's borderline, like I think I can operate. I wonder what their PROMs say, because if they're functioning at X level, maybe I shouldn't actually operate because they're already functioning that well.
Right.
But if I'm, hemming and hawing about whether I should offer surgery, and I look and their pain is the worst I've seen in this condition, I'll probably do surgery.
Right.
Right? That's how it's valuable. And we measure...
Should be a complement to your decision making.
It's like a lab value. And frankly, in orthopedics, it's way more valuable than vital signs. Yeah. That's the other thing that drives me nuts.
Maybe refer to internal medicine in that case.
Yeah. But like that's the other thing that drives me nuts is in a clinic, like people, like physicians, and understandably so, just because it hasn't been part of the routine, they'll be like, no, it's going to slow me down. First of all, the research shows it doesn't do that, and you're usually behind anyway. So that's beside the point. The second part that usually comes up is they're like, well, I don't know if I'll use it, and it goes back to the using point. But it's another tool, and frankly, it's way more important than vital signs. Obviously, if a vital sign is grossly abnormal, sure, but 99.9% of the time, it just goes dot phrase into a note,
right,
never to be looked at again.
Right.
Where this is actually tangible data that when you share with a patient, and when you go to a patient, you say, look, I know you're having a lot of pain, but actually for someone for your condition, in a perfect world, I would love a situation where a patient comes in and they're like, I have an ankle fracture. What is the chance? How long will it take me to get better? And what is the chance of people with my comorbidities, etc., reach X? And I want to be able to say, and I can't yet, I want to be able to say, patients like you with your comorbidities that I've treated or our hospital has treated reach this level in the PROMs that we collect, and some PROMs are based on populations, and you can say, on average, you're actually going to be better than 50% of the people, or you're already functionally worse than 50% of the people. I mean, having that ability to do it. At the moment, we still cite like, oh yeah, patients do great. They don't come back. They don't need a revision.
Right.
I mean, it's just not an acceptable answer.
So this is something that I really want to ask you is, if tomorrow you receive the position of Secretary of Value-Based Healthcare in the United States,
new position.
What is your first action order?
Collect outcomes that matter to patients.
Okay.
Get rid of most of CMS's quality metrics of like how many steps does it take to, whatever it is. One of the things about the relationship of the value equation is if you don't know what the outcomes are or you don't improve outcomes, the value, if you want a value, the value is zero. It doesn't matter how low you reduce cost. Right? If you don't know the numerator and it's zero, it's zero. The answer is zero. Measure what matters to patients. The fact that that's not routine is mind-boggling. And if I hear one more excuse about like, we have examples like use an Excel spreadsheet.
Yeah.
Like your patients should know what they're doing. And it's not to say that people don't want to or they're bad. The surgeons are fantastic, the physicians are fantastic, the health systems do amazing work, but just measure it. Right. Measure it. In every other industry we measure.
So what would you do to implement that measurement directive?
Yeah, so I think we're already seeing it, because I think CMS is getting fed up and they're like, so total joints, you must collect certain PROMs by certain year in order to get paid, and then a few years after that, you need your change of PROMs to be a certain amount or you get dinged. They're already implementing it because they're like, look, we're kind of fed up.
So they're twisting the financial arm right now?
Well, yeah, exactly, because, but a lot of these outcome measures are like, outcome measures, they're really just quality metrics of processes are that way. The Joint Commission, for example, has such a big lever of saying, measure what's important to patients. Instead, at the moment, they do a lot of important work for safety, but they're like, what is the width of a hallway? Things that are important because you need the bed to fit, but focus on the patient.
Right.
Right? To me, it's supplementary. It's not that you replace one with the other. It's supplementary. So I would say measure outcomes. Measure outcomes. Measure them routinely. And I think what's important is there's an overall strategy measuring outcomes. There should be national strategies, like which ones, how, whatever. And at the local level, how you implement it, you need to give enough flexibility to not penalize people who are doing their best to collect something that they haven't historically done because they don't have the $1 million to invest in X, Y, or Z.
Right.
So there are variations, and there should be acceptable width of options.
Right.
But the fact that it's not the norm to measure the outcomes that matter most to patients to me is still mind-boggling.
Yeah.
And it's very hard to convince me.
What do you think, Henri?
Yeah.
What's your first order
My first order?
Yeah.
I think it's help people implement them as well. I think there's such a broad array of problems, and it's, you have a big overlap and a widely different spread in patient necessities as well. You have a patient with congestive heart failure and you have a pregnant woman, and a lot of the problems scores that they can fill out can be widely similar and widely different at the same time to measure kind of
should
the same
just
things.
decrease the confusion and the variability in the
make
process.
That, and also provide benefit to the healthcare providers for using them, because that's in the end what's going to get them to actually implement them in daily practice. Help them, find a system to better choose which patients they attribute more time to.
Maybe a credit score clinic. for collecting value-based health
credit score is
metrics.
not really, more like make their life easier as well, right? Like the providers are overwhelmed with too many patients. If you have patients that come in with prom scores that are widely off the chart, you know that you might probably be better off allocating more time to these patients in your outpatient clinic than patients that come in with above average scores for an intervention, for instance. You can go in and have a short visit with them. You can triage patients differently. In the end, spreading your time more, and hopefully you're not as behind on your outpatient clinics in the end.
Right.
Yeah. And the other thing that's amazing about PROMs is, so two things. One, there's a group called the International Consortium for Health Outcomes Measurement, so ICHOM, that is trying to standardize it. Because one of the things we don't do is standardize it, right? Like there are 15 different functional ones. So either complete all the crosswalks, meaning that you measure on one and you can get to the one that they want at the government level, so that you can say sure, I like this because this is whatever, context specific, cultural specific. It's completely fine. I have no problem. First of all, just measure something. But I have no problem. Yeah, do something. But I have no problem if you want to use this instrument, as long as you have the crosswalk to the one that the government wants to then compare broadly. So that, I think, is really an important aspect to give clinicians and hospitals and health systems, et cetera, kind of the flexibility and leniency to choose what they like. But the point that I think is really important is you have a congestive heart failure patient. Perfect example. You still measure function, because the questions that are asked in a lot of those questionnaires are how far can you walk? That's actually extraordinarily indicative of how their heart's functioning. They're I get really short of breath by step 5 and I can't go anywhere. I mean, it's not that you just use the same all the way across the board, but there's much more overlap that I think people tend to appreciate.
Right.
And the other thing that I think Henri brought up that is incredibly important is value-based healthcare is a burnout preventer. Period. It realigns why you went into healthcare. You get a sum of money to care for a patient in the way that you want to care for that patient. You don't have to ask anybody for prior auth. You don't have to change the way you do something. If you do surgery or you don't do surgery, you're not rewarded or penalized based on it. I mean, at the moment, doing surgery, part of the problem with the bundle payments from CMS is they're doing incredible work trying to move this forward, but it has nothing to do with appropriateness. So if you're paid as a physician on RVUs and you think someone may benefit, you have to go into that bundle. It's a procedure bundle and not a condition bundle.
Right.
And so you have to get into it. And so I think that, if you look at places like Dell Medical School, is again a perfect example with Kevin Boza, who's the president of the Academy this year, the American Academy of Orthopedic Surgeons. He and Carl Koenig, who's the division chief for Musculoskeletal Institute and Orthopedics, and PJ, have done unbelievable work. And everybody is happy because they're all aligned. Their job is to care for patients, and they don't get penalized or rewarded financially or otherwise for doing more surgery or doing less surgery.
So the reward is not only to the patients and the people that are receiving the care, but also the providers as well. So it's a two-way street.
And that's why no one leaves there.
Right.
That is why no one leaves there. They are happy.
That's the best retention tool ever, huh, for an institution.
Value-based healthcare is a burnout preventer,
Right.
and it realigns and it reinforces why people went into healthcare.
Right.
It's not the like, well, you make no money. It's not that why you went into healthcare is reinforced in the model
Mm-hmm.
versus not in another where, you're told, well, the system really needs you to do more and more and more and more because we get paid by volume.
It's internalizing or internalizing the factors that help us do what we do better instead of externalizing it and say that's how the system works and that's how it is.
Patient-centered approach, I think.
Yeah,
That's
giving
the idea
more
at the
like
end
a
of the
sense
day.
of control to the providers and the patients themselves when it comes to their care, instead of saying like that's how it is, that's how it's always been, and which is also something that drives burnout.
Yeah.
Right, the way we have been thinking for years now,
Yeah.
when we externalize the value of our care.
Right. If we refocused on why we went into healthcare, that's how you prevent burnout. It's not modules. It's not like bringing in puppies. It's not yoga.
Wellness checks.
Yeah, it's really focusing and letting physicians practice healthcare the way they want to.
Right.
It's not saying, again, one of the things that I think is really frustrating just in general is when you make statements, people are like, but here's the example when it doesn't mean no guardrails, right? Like people are like, well, if you do that, like what happens if they overutilize? I mean, it's not no guardrails. It's not that we just pay for everything and ignore out. But if you measure the outcomes and the cost, you have an idea and you can have a more informed discussion. And it's hard. It's obviously not easy. I mean, MGB is doing fantastic work and trying to push this forward. Vanderbilt and their CEO and Dean Jeff Balzer is a leader in this area. And so it's not that health systems don't want to. It's a lot of it is the struggle of trying to make themselves sustainable in the model now to fund and innovate in the future while getting payers and government and other people to come along. That's why this is a journey. That's why when you read the articles that are like, well, value-based healthcare doesn't work. I mean, if you 15 years ago, 20 years ago, looked at SpaceX, it's not that long ago, but looked at SpaceX and said, well, they haven't been to the outer space yet and it's been 5 years, SpaceX doesn't work. I think Elon Musk would be like, first of all, he said, give me a break. Second of all, as a brilliant guy who's invented so many, he's like, yeah, I can't go to space tomorrow, but we will get there.
Right.
And it's
It's a mission. It's not. Yeah.
Yeah, it's a long-term goal because
Right.
the current system is just not sustainable.
Definitely. Well, this is really interesting. This is a really interesting discussion in general, and a topic that I think deserves more time and more conversations. And I'm really, really happy and excited about the future of this, knowing that people like you, Henri and David, are pouring their efforts into developing this and allowing the healthcare system to take that big stride forward. I want to thank you all for being here today and talking, and I wish I had more time to talk to you guys, but we need to limit these episodes. But I'm really happy to talk to you today. And is there anything that you would like to conclude with? Any final words on this topic? Anything you would like to talk about at the end, Henri?
I don't think so at the moment. I think make sure you collect your prompts. That's the biggest one at the moment for me.
Yeah. I just want to say that I think that there's a lot of great people doing a lot of amazing work, and it's taking steps in the right direction. It's not all or nothing. It's not, calling something value-based healthcare, designing it poorly, and then saying value-based healthcare doesn't work. We need to be very clear on the definition, and we need to take steps. This is an overarching strategy. It's not a 0-1 game, and I think as we continue to move towards trying to create a sustainable, resilient health system that can deal with the influx of an aging population, this is the right move. And I may be wrong. That's also right, and that's the other thing that I think is really important is that as we start doing more and more, we may find that we need to measure this in a different way, or we need to we need to make sure it's below this cost from a societal standpoint. But in order to know that, you need to
Right.
measure both those
You need to
things.
do the work and find
You need
out
to
whether
do
it's
the work.
working or
And
not.
so
Yep.
To just make kind of bold out statements, I think is doing an injustice to the work
Absolutely.
altogether.
Absolutely. Well, thank you so much.
Thank you.
Yeah. David Bernstein, Henri Ullmann, and myself, Samir Ghandour. Hopefully see everyone on the next episode. Please follow us on social media and see our other episodes on YouTube. Thank you, everyone.
Thank you.
All right.
Thanks.